Good day, everyone. My name is Mylène Simoneau, and I am the Women's Wellness Coordinator at PSP headquarters.
And good day, everyone. My name is Anna Smith. I'm the Women's Wellness Program Manager. We are delighted to have this important discussion today on perimenopause, which marks the beginning of many other initiatives focused on menopause to come from PSP. So thank you for your interest and for joining us today.
On behalf of our team, I am pleased to welcome you to today's Ask a Doctor webinar featuring Dr. Hansen, entitled Perimenopause. What is it? Are you in it? And why it matters. Please note that this session is being recorded and will be available for viewing on our website after the event. For your privacy, your cameras and microphones are disabled throughout the webinar. If you have questions or comments, you may submit them at any time using the MS Teams Q&A feature. While we will do our best to address as many questions as possible, we may not be able to respond to all today. Unanswered questions may be covered in future sessions. If you wish to listen to the session in another language, you may use the Wordly link provided in the discussion panel to access live translation options. Today's presentation is intended for educational purposes only and does not replace advice from a qualified healthcare professional. If you have personal or specific health concerns, we encourage you to speak with your healthcare provider. So without further ado, it is my pleasure to introduce our presenter, Dr. Catherine Hansen, Canadian-trained and U.S. board-certified obstetrician-gynecologist, menopause practitioner, and health advocate. Dr. Hansen, thank you for being here virtually with us today, and over to you.
Thank you so much, Mylène, Anna, PSP, and all of the people who've decided to attend today to listen in about perimenopause. It's really exciting to be with you and to be having this conversation. So I am, as you heard, Catherine Hansen, and the en français version of this presentation was given yesterday by Dr. McCall. The recording will be available in both languages shortly on the webpage, and we're really excited to be collaborating on this program together. We have a couple of disclosures just in terms of advisory boards and roles and consulting roles that we both take. And moving right into a land acknowledgement. So this land, wherever we are, is the traditional and ancestral territories of countless Indigenous nations. I'm coming to you from Houston, Texas today, but I reside in the area of near Ottawa, Ontario, during most of the summer months. We acknowledge that we are guests on this land and we pay respects to elders past and present. Menopause in Indigenous women in Canada remains understudied, and colonization impacts the way menopause is experienced and shared among Indigenous peoples. You've heard our medical disclosure already. And important to understand that each person's experience of menopause is unique. People who are transgender, non-binary, or intersex may also experience menopause in unique ways. More research is needed to understand the impact of menopause on women and women in diverse communities. So we're going to define perimenopause, differentiate it from menopause. Really looking forward to your questions. We have some pre-submitted that I will go through as well. And it is really quite often a question, what is menopause? Am I entering perimenopause? And we're really happy to unpack that today. We're going to identify main symptoms of perimenopause, review preventative and management strategies for perimenopause and some of the biological changes that happen around that time frame, provide an opportunity to ask questions related to this stage of life, and leave with a sense of agency and empowerment to assist and support you in negotiating your or people you love and care about's perimenopausal transition. So what is perimenopause? Perimenopause is essentially related to a decline in ovarian function. There's a loss of estrogen, and that loss of estrogen results in various tissue and biological changes. Those changes can occur. One of the pre-submitted questions was around perimenopause how long is it? And so giving you an idea here, it is an average of about 4 years, starting in the mid 40s. Average age of onset is around 47, but I've seen women in the late 30s and early 40s with onset of perimenopausal symptoms. Average lasts 4 years, as I said, but it can last as long as 10. So you can tell from this graph, there starts to be a decline in estrogen levels. There's an onset of symptoms, hot flashes, night sweats, insomnia, mood changes. We'll unpack all of that. And as the estrogen declines, there are changes in other organ systems as well. So some urogenital, which are vaginal and bladder symptoms, changes in bone health, brain health, all the organs become impacted over time from those hormonal changes. So how do you know you're in it? The Menopause Society and the international menopause communities have defined perimenopause as a change in the menstrual cycles of over 7-day difference. So if your menstrual cycles originally are 28 days, and then you have, say, a 24-day cycle, because often they get shorter before they get longer. So if you have a 24-day cycle from day one of bleeding to day one of bleeding, and then it goes to, say, a 35-day cycle, now your variable menstrual cycle is more than 7 days, you're likely in the perimenopause transition. And ultimately, that interval will, in the later perimenopause transition, that interval will get longer than 60 days. So actually skipping some cycles. And that's how you absolutely know you're in perimenopause. And then, of course, menopause, by definition, is a year after the final menstrual period. So at the top of this chart, you see FMP, that's final menstrual period. And when final menstrual period occurs, you need another 12 months before you're, by definition, into actual menopause. The rest is perimenopause. So are you in perimenopause? Well, tracking your cycles, making sure that you know if there's more than 7-day variability. Are they getting shorter? Are they getting longer? And then also some variable flow. Are they lighter? Are they heavier? And we know that there are sometimes such changes in ovulation that there's 2 ovulatory cycles in a month. That's called a loop. And what happens with 2 ovulatory cycles is you ovulate, but then there's an increase in estrogen related to that ovulation, and then another ovulation. This happens to about a third of people. And because of that extra ovulation, there's an increase in the lining of the uterus, and there can be a very, very heavy flow. So some perimenopausal patients will describe a really heavy menstrual flow, while others, it just seems to get lighter and lighter over time. Seeing if you have some of those symptoms we talked about, hot flashes, night sweats, brain fog, mood irritability. You really don't need blood tests in order to know if you're perimenopausal. It's related to these symptoms and menstrual cycle changes. We did get a pre-submitted question around how do I know if I'm in perimenopause, if I'm on a hormonal type of treatment or a hormonal contraception, for example, an oral contraceptive pill, a combined hormonal contraceptive in the form of a patch or a vaginal ring. And these make menstrual cycles regular. In other words, the menstrual cycle you're having, if you're taking those medications, are withdrawal cycles. They're not actually your ovaries or your biological flow. And so it's really hard to track your cycles because you're already having hormonal balancing with those options. And so you'd have to be off of those options to be able to see if your cycle's changing. But if you're having perimenopausal symptoms or symptoms that we're talking about today, and you're taking a contraceptive, then it's important to talk to your provider about maybe being off it, maybe adjusting it, maybe there's something else that can be done about those symptoms. And another question was related to, well, what if I'm using an IUD or an intrauterine contraceptive device that shuts down or slows or lightens my blood flow? Same type of thing. You may be getting some symptoms over top of using that IUD, but having that IUD in is going to alter your cycles, making it harder to track and maybe a little harder to know if you're in perimenopause. But regardless, there's really no need to have blood tests done to know if you're perimenopausal. What are some symptoms? Vasomotor symptoms happen to be the most common. They occur sometimes in the day. We call them hot flashes. At night, we call them night sweats. They can be accompanied by other symptoms: sweats, perspiration, chills, anxiety, heart palpitations, sudden intense sensation of heat. Kind of women describe it as heat that comes from inside the body, not like an outer heat like your room is hot, but like from inside your core. They last through 30 seconds to 5 minutes. They can come very frequently through the day or infrequently. And even if they come infrequently, they can cause some significant bothersome problems for people. It's hard to concentrate when you're having a hot flash, for example. And they're most bothersome during the later part of perimenopause and early menopause. Normally, when the estrogen starts to decline quite significantly and consistently, the hot flashes will continue to increase. Now, not everybody has them. They affect up to 80% of women during the menopause transition. And premenopausally, some women will start to notice about 20%, perimenopause about 40%, and postmenopause stays at around 40%. And we hear as high as 75%, but average being about 40% of people will have vasomotor symptoms. So if you don't have them, doesn't necessarily mean you're not in perimenopause. It just means you're one of these people who maybe is going to get away with not having vasomotor symptoms, maybe some of the other symptoms, or maybe none at all. And I think it's really important that we're clear that some people can get through perimenopause and menopause without any symptoms, really smooth sailing all the way through. And so that can be your case as well. Even if that is you and you have no symptoms, there's still very important considerations related to that declining estrogen or declining hormone levels. Vasomotor symptoms can last for about 7 years, sometimes up to 10 years. People ask me, will I always have these? Yes, some people have their vasomotor symptoms for more than 20 years or all the way through their entire health span or lifespan after menopause. We know that there's some ethnic and racial diversity in the symptomatology, and each person is unique, as we said. So we know that African American women have longer onset of menopause, perimenopausal symptoms, and vasomotor symptoms. We know that Japanese or Asian women sometimes have lesser degree of symptoms, lesser duration, less bothersome symptoms. We wonder, some of the studies are curious around whether this is related to diet. We're going to talk a bit about nutrition today, but if you think about a typical Japanese diet compared to a typical North American diet, very different. There are some studies which show that more fish, more legumes, more vegetables may delay the onset of menopausal symptoms, and refined carbs, or what we call the standard American diet, is often leading to an acceleration of menopausal symptoms. So we'll unpack more about diet shortly. What other symptoms occur? Sleep can be disrupted related to estrogen decline, mood or irritability, brain fog or cognitive changes, muscle joint aches and pains, skin and hair changes, weight gain or body composition changes, headaches or increasing menstrual migraines or cyclic migraines around cycle changes or hormone changes, and a decrease in libido. We had a pre-submitted question around circulation. Can menopause or perimenopause cause my hands and feet to be cold? Well, we know that with vasomotor symptoms, for example, there's a central change in thermal regulation. And so certainly this can disrupt a sense of feeling hot or cold overall. Estrogen also, interestingly, changes blood vessels. And so a declining estrogen can sometimes lead to like a vasoconstriction, so less blood supply to certain appendages, to fingers, toes, hands, and feet. But the studies are not really clear that cold hands and feet are definitely a perimenopausal symptom. You'll see they're not actually listed here. So if you're having symptoms that are a concern, it's worth having looked at. For example, cold hands and feet can be related to autoimmune processes or connective tissue issues as well, Raynaud's or Sjogren's syndrome, things like that. So worth having checked out if it doesn't go along with other common perimenopausal symptoms. We hear a lot about weight gain in perimenopause and menopause, and I think it's really important that we understand that while there is generally about a 5 pound sort of increase over time in the perimenopausal time frame, then it actually is a bit different than weight. It's actually a shift in body composition, and we know that there tends to be a decrease in lean mass and an increase in fat mass. So proportion of fat gets higher, proportion of muscle gets lower, and that can also contribute to this change in body composition and this change in body weight. And that is one of the reasons that we're here today talking about perimenopause and ways that we can prevent or mitigate some of the changes that are occurring over time. Was there a question? I can certainly pause if there was a question. I'm happy to do so.
Yes, we have a quick question on clarifying what is the difference between premenopause and perimenopause?
Ah, very good. So premenopause, we use that to mean that people who are not in the menopause transition, they're not in perimenopause, they're not in menopause, and so that would be everybody else in the reproductive age category, according to that straw graph that we saw. And I'm trying to think if it's how many pages to go back, but I think these questions are really important and for us to understand. If we look at the straw category, you'll see the reproductive age range working backwards from the final menstrual period, and then menarche is when a woman has her very first period. So between your very first period and your very last period, there's the reproductive age range. So early peak reproductive age, late reproductive age, and then we start, that's all pre-menopause. And then perimenopause, of course, the word peri from Latin meaning around the time of, so around the time of menopause would be that early and late perimenopausal transition, which is now beyond the reproductive ages. Now, that doesn't mean you can't have pregnancies into the perimenopausal timeframe. You absolutely can, but knowing that you're getting into that transition because of those declining estrogen levels. So just watch your eyes, and I'm going to skip back ahead where we were, and happy to take more questions on that. Are there more questions?
No, not at the moment. Thank you for the clarification.
Okay. And so moving on with more sort of detail around symptomatology, we know that there's mood and mental health concerns around the time of perimenopause or with declining estrogen and progesterone levels. Irritability, this is one of the things that a lot of women will come into the office to describe. It's rage, it's internal anger, it's resentment, it's these feelings that are almost uncontrollable and really misunderstood because women don't really know why they're feeling the way they're feeling. And of course, they're looking for reasons outside of their hormones and their biology, and so they get angry at the people around them. Can create stress, anxiety. We talked about heart palpitations, depression, a real vulnerability to stress or trauma because of the decreased reserves around emotional agility and emotional resilience because of these hormone changes. We know that ADHD and neurodiversity can either be exacerbated or can actually have new onset in the midlife perimenopausal timeframe related to these hormone changes. And perimenopause can unmask underlying mental health conditions or also unmask underlying neurodiversity as well. So we notice that perimenopausal women can be newly diagnosed with ADHD, or ADHD can get worse. So attention deficit hyperactivity disorder can certainly get worse. We did have pre-submitted question around neurodiversity, and it behooves us to realize that there's a critical gap in research around perimenopause, menopause, and neurodiversity. But sticking to what we know to be the mainstay of treatment for neurodiversity with medical regimes overall, it's important to individualize treatment and care to always accommodate specific and unique needs of every patient. And with neurodiversity, to be really collaborative in relationship and around treatment options. Sometimes there's a sensitivity, so there's a nervous system sensitivity to swallowing or GI sensitivities, so be thinking about gels or transdermal applications versus having to swallow pills. Very clear written instructions. Cognitive behavioral therapy, which is a very well-studied and credible management option for perimenopause and menopause, is also really helpful in the neurodiverse community, but to be self-paced and self-guided and really allow each person to pace themselves and determine what it is that they need individually, and to consider treating any comorbidities or any co-occurring mental health issues with neurodiversity, such as anxiety, depression, which may be new onset or exacerbated. We know with perimenopause, there's a reduced memory and brain fog, and there are actual structured cognitive tests that show a reduction in executive cognitive function, but don't worry, it's transient. It may be related to, we're uncertain, but may be related to lack of sleep, may be related to vasomotor symptoms, but ultimately it is transient, and cognition, although brain fog is very real, does eventually resolve. How do we manage mental health conditions around perimenopause? We do so with menopausal hormone therapy. If the main problem is a declining estrogen, declining progesterone levels, menopausal hormone therapy is the mainstay of treatment, because providing those hormones is actually going to mitigate a lot of those symptoms. Your provider may recommend antidepressants or selective serotonin reuptake inhibitors or selective norepinephrine reuptake inhibitors. That's not because you're depressed. It's because antidepressants actually treat some of the central causes for vasomotor symptoms and can be very helpful, specific for menopause, as well as helpful for depression and anxiety, for example. So if the main symptom that you're experiencing is depression, anxiety, then, and also vasomotor symptoms, antidepressants are going to work for all of those things and may be your best option. Cognitive behavioral therapy involving questioning assumptions, involving journaling and guided practices. This is a certified credible, well-studied treatment option for menopause and perimenopause, and mind-body therapies, because we actually have studies to show that women and people who anticipate that their perimenopause and menopause is going to be manageable, and that they have resources and they have supports in place, actually have less tracked symptoms, actually have less physiologic symptoms if they're anticipating that their menopause is going to be less severe. And so isn't that interesting that there is this ongoing mind-body connection? We know there's decreasing libido affecting 1 in 4 women, could begin a couple of years before the final menstrual period. It's multifactorial, so really no easy answer. And I like to share this Rosemary Basson graphic. I have a couple of these. And starting in the top left, people often want to say, okay, this is my hormones. Give me something that will help me with my libido. And yes, that can be the case in some situations. And there may be this as a factor in a decreased libido. But there's also a lot of other factors, such as relationship or partner problems or dysfunction, relationship discord, lack of intimacy. We are all living in this really busy, chaotic world. Do we take time to be intimate? Do we take time to connect emotionally? Do we have the time we need to set aside for creative sexual play, for example? We know that there's a lot of overlying potential history of trauma, physical, mental, and so there tends to be in situations a lot of potential negative emotions, fear, shame, guilt. Even from childhood, I see a lot of patients that are just raised to anticipate that sexual creativity, sexual play is bad or wrong somehow, and that overlays into the sexual relationship. There may be a lack of privacy. We're in this sandwich generation where, as women, we are looking after teenage children, we're looking after ailing parents. There may be really no space in our life to set aside and to shut our brains down in order to enjoy a sexual experience. Or this negative feedback loop of, it wasn't so great last time, so why would I bother trying again? And so these are the multifaceted areas of a sexual response cycle, sexual health, that we need to consider, not just a quick pill or a quick fix, where often we need to be looking at the whole picture. So this graphic shares a model that we understand to be a little bit more indicative of a midlife, perimenopause, or menopausal relationship, where spontaneous sexual drive, the biological drive, used to be what led us to being in a sexual situation. Versus as we get older, as life goes on, as our bodies age, our minds age, and things in life become potentially more important or distracting, we often become sexually stimulated in a responsive way. So not necessarily thinking about it spontaneously, but being receptive to the sexual stimuli, being receptive to, maybe I'll put it on the calendar, or yes, I've had a lovely time with my partner. I would love to be playing in a more intimate sexual way, and just being willing, essentially. And having that sexual stimuli leading to biologic and psychological arousal, because for many patients I've had, once they get into that level of arousal, they're in it and things are working well. It's just they didn't have time to actually set aside the time to do that. And so they felt like their libido was in their boots, when in fact when they did create the spaciousness and the emotional connection with their partner, their sexual response was actually very normal and very healthy and very satisfying. So leading to the physical arousal, the emotional arousal, and the emotional intimacy that so many women are craving, especially around this midlife time frame. And so realizing that responsiveness to sexual activity is part of a normal sexual cycle. And so management of libido issues could be menopausal hormone therapy, could be treating any pain that's occurring, could be testosterone. Although in my vast experience with testosterone in my practice, it doesn't work as well or as easily or without side effects as many people think. So it's not the magic cure. Flibanserin, or also called a D, in the studies reveals about the same improvement in sexual response as placebo does. Well, a placebo could create an increase in sexual response just because people think they're taking something that's going to make it better. And a D has a very similar response to placebo. And relationship care is really vital as a management option, not to be underestimated. We know that sometimes when there are libido issues, it can identify a real opportunity to lean into a relationship, to reconnect, to set valuable priorities together, to grow together. And what's really special about sex is not just the sex itself, it's what it does to create that connection between people. And perimenopause, with all the things that we've talked about, what is it that's really important that we need to do? So if you're in that time frame, late 30s, early 40s, coming into that transition, whether you're having symptoms or not, what can we do? Well, it's so important to be having this conversation because there's things that you can and should be doing now, regardless of your age. and that is exercise, healthy diet and nutrition, restorative sleep for that brain health and overall longevity, managing stress, because stress, as you are likely aware, has many physical ramifications, quitting smoking if you smoke, reduce alcohol, even cannabis use or drug use should be mitigated or managed or reduced. And this is really very important education, again, even if you're not having symptoms, because there are many things that you can do that will prevent or lessen or reduce any trouble that may be coming down the road. So exercise being really important, as we've said many times, because of those body composition changes that I discussed. So right around the time of perimenopause, there's about a 50% decline in estrogen. Estrogen is one of the major hormones that maintains bones. And so with that massive steep slope decline in estrogen levels, bone health is probably the most important consideration. So exercise needs to change a little bit in terms of what you do to protect your bones. It involves lifting heavy, obviously doing it always in a safe situation. It involves some impact so that your bones are being stressed and will continue to maintain their strength. And so bone health is really important, and exercise is going to provide all kinds of benefits in addition to bone health, muscle strength, muscle metabolism. The more you maintain muscle, the more you maintain your metabolism, which ultimately can reduce ongoing issues that can develop, such as cardiovascular disease or diabetes. So you want to have a good metabolic health. Quality of life, we know that falls, for example, in older age groups are one of the main impetus for decreased quality of life. So a fall, a fracture, a broken hip, for example, has a really high morbidity and mortality rate. Exercise is very directly linked to mental health. So if you are an endurance athlete, for example, you'll know that when you're out for a run, you sometimes get that runner's high, and that's a real thing. So regular exercise is going to maintain mental health as well as confidence, reduce mortality. And looping back to the libido conversation, being healthy and exercising regularly has also been shown to improve the quality of your sex life, your sexual satisfaction as well. And that may be related to maintaining circulation to all of your important organs, including your sexual health organs. Diet and nutrition. So Dr. Samia Mora is she's a Harvard cardiovascular physician. So following a Mediterranean diet pattern could result in about 1/4 reduction in risk of death over more than 25 years, with benefit for both cancer and cardiovascular mortality, which are the top causes of death in women and men in the U.S. and globally. So this Mediterranean diet is probably the mainstay of and has been shown in most of the credible, robust data to be the healthiest diet pattern overall. Now, different diet patterns are important for different health goals. So if you're looking to lose weight, for example, or you're looking specifically at bone health, or you're looking at diabetes control, it may be different. But overall, for longevity and overall health in a generally healthy population, the Mediterranean diet is usually the best. Canada's Food Guide has done a really good job in, I'd say, the last 10 years of recent updates, showing us that we need lots of colors on our plate, lots of leafy greens, plant-forward, healthy proteins, minimizing carbs, but when we do, making sure they're whole grain, not just grain or flour, but actual whole grain, which has specific nutrients and fiber in it. We want to ensure that we are prioritizing protein and plants, that protein timing matters, that protein quality, quantity, and digestibility also matter, and that exercise is essential, because what exercise is doing is helping your muscles integrate the protein. So sleep, also really vital for all of the ripple effects. So in today's world, sleep is often sacrificed due to busyness, stress, or the lure of technology. It's not just an optional add-on, it's a critical component of human health and well-being. So before we unpack sleep, I'll pause and take another question.
Yes, we have a question more on nutrition. So, is creatine a good option to supplement their diet for muscle, bone, and the brain? Is it worth it?
Yeah, such an excellent question. So there are studies on creatine in terms of in the medical scientific literature, those studies are still evolving. But what I can share is there are some emerging studies, again, not the highest quality or the best randomized control trials, but there are some emerging studies showing that creatine has an effect on cognitive function and has an effect on helping or assisting with Alzheimer's disease, so mild cognitive decline and or early onset Alzheimer's. Sometimes creatine daily in about a 3 to 5 milligram dose can help with cognitive function in some of those studies. In terms of bone, I haven't read anything specifically on bone, but in terms of muscle, creatine monohydrate is going to be basically it is normally produced in the muscle, and so it actually draws water into the muscle. We know that the muscle actin and myosin fibers, and I know I'm speaking to a lot of exercise physiologists. We know that water is just going to make that muscle work more effectively, more efficiently. And so there is some thought that creating sort of a hypertrophy in the muscle by drawing water into the muscle may have a beneficial effect on the effectiveness of that muscle. In other words, maybe you can lift a little heavier, maybe you can have a little bit more of a training effect. And so studies have shown hypertrophy in the muscle with creatine monohydrate, again, in the range of about 5 milligrams a day. And the studies, I think, need to continue for us to really be able to answer that question in terms of long-term impact. If I were advising a patient, I'd want to know their health goals and exactly what we were using it for, as with any supplement, because these things are expensive, not always completely studied the best, and we have to weigh the pros and the cons in terms of what those health goals are.
Thank you. We have two more questions regarding nutrition. So first one, is it necessary to increase protein consumption during perimenopause? And if so, at what level? So how many grams per pound or per kilogram of weight?
Yeah, so good, so good. I mean, I think we could spend a couple of days unpacking protein, and I think that there's so many different viewpoints on protein. So I'll give you the overview of what I would recommend. And I think it's important to make sure that your own providers, potentially your own trainers and support system are also impacting your decisions. Um, Perimenopause and menopause specifically do require protein consumption, not necessarily more, but my experience is that midlife women in general are probably not taking in enough protein. So it's in the realm of about 1 gram per kilogram per day. And if you think about how much that is and you track your macros, you'll see probably for most of us, not everybody, but for most of us, it's really hard to hit that. I generally advise patients to try really hard for 25 grams per meal and an additional 25 over snacks. And if my patients in that sort of normal, let's say healthy perimenopausal age range are doing regular exercise and they're taking in that 100 grams a day of protein, they're doing a really good job. There are schools of thought that we need to be almost doubling that protein consumption. There's likely no harm in that. The only harm in over consuming protein is that protein, as with any other macro, turns to fat if it's not used. So protein over consumption of protein could lead to increasing weight or fat deposition. I don't think there's many people who get to that level of protein consumption without real intentional effort.
Yeah, thank you. And then one more on nutrition for now. The question is, Is collagen also a good supplement to take for the skin changes?
Yeah, so the specific answer to is collagen good for skin changes is likely not. The literature is not showing that that's really come out in scientific studies. A lot of that's promoted, all over our socials, but it's really not science-based that collagen consumption is going to help with skin, hair, nails, etc., just by the way it's metabolized in our digestive system.
Thank you.
Yeah.
Let's jump back into the sleep.
Okay, great questions. I love this open dialogue. This is the fun part is hearing what you want to know more about. So we're talking about sleep, and we know that estrogen declines, progesterone declines, and because of those declines, there tends to be hot night sweats, at night thermoregulatory dysfunction. I don't know about you, but I'm turning my bedroom down to very, very cold temperatures at night these days. It really helps with sleep, and that has been shown to be part of sleep hygiene is to have a cool, dark room. And then because of these hormone changes, there's changes in sleep architecture. So sometimes harder to get into deep sleep patterns or REM sleep, which is where most of the restoration occurs. We know that perimenopause triples insomnia risk and that insomnia triples depression risk. So you can see the ripple effect of the sleep. If there's one thing that I would advise people to really double down on, it's sleep and sleep hygiene. And if that means off devices, calming, a cup of tea, no phone or TV or screens at all for an hour before bed. And the literature says 30 minutes, but the longer the better. And really going to bed at an earlier time, because earlier is when you get your deeper sleep. Most people's deep sleep occurs sometime before midnight or 1 a.m. So if you're not in bed till midnight or 1 a.m., it's hard to get those deep sleep cycles. If there's one thing I would highly recommend, it's really doubling down on sleep restoration because that's going to help every organ system, including brain health. And as we're talking about the ability to exercise, the ability to continue training, to maintain bone and muscle health, it's all related. And it can all be traced back to sleep in certain situations. So hormone and non-hormone therapies for sleep dysfunction would be menopausal hormone therapy, exercise we've talked about, sleep hygiene, and mindfulness. And there's a certain cognitive behavioral therapy certification in insomnia, which has good scientific evidence for benefit. So we know memory and learning consolidation occurs during those deeper sleep cycles, reducing inflammation throughout the body and including in the brain, cardiovascular and metabolic health, such as blood pressure, insulin sensitivity, cortisol, and inflammation are all marked and improved by more restorative sleep. What are some other treatments for some of the other symptoms that we talked about? I like to group menopausal therapy options into three categories. There's hormonal, there's prescriptions that are non-hormonal, and there's non-prescription options. The mainstay of treatment is menopausal hormone therapy. Menopausal hormone therapy would have some contraindications, and some of those would be a personal history of stroke or heart attack, as well. That would require conversation. It's actually not an absolute contraindication, but we'd want to talk to cardiology with those situations. Breast cancer, whether hormone dependent or independent, we would want to work and collaborate with your oncologist in that situation. But most of the time, systemic menopausal estrogen and progesterone, so taking them in a pill or a patch or a gel, would be better for women who are not breast cancer survivors. And for most other women, menopausal hormone therapy is going to work the best. Non-hormonal prescriptions, things like SSRIs, SNRIs, antidepressants, and some of the neurokinin 1 and 3 antagonists. So those are newer on the market, Veoza and Elinzatant. are also effective for vasomotor symptoms, and then non-prescription options. We talked about cognitive behavioral therapy, hypnosis, etc. Now, in the perimenopausal timeframe, one of the main considerations for treatment is cycle control. So the main symptom is a change in the cycle, sometimes heavier cycles or unpredictable cycles. And so cycle control is really important when we consider what we want to manage, what we want to do to manage perimenopausal symptoms. So to manage heavy periods, for example, there's non-hormones like tranexamic acid or ibuprofen or NSAIDs. There's hormonal options, which would include a birth control pill, either an estrogen progesterone or progesterone only. And then there's patch, vaginal ring, and then there's long acting like an intrauterine device, a Depo-Provera shot, or an implant. And in some situations, perimenopause symptoms can be managed with menopausal hormone therapy. And in some situations, it actually needs or requires better cycle control, which is managed with a combined or a contraceptive option that is for reproductive age women as well. So like a birth control pill, for example. So to summarize that, menopausal hormone therapy can work in perimenopause, and sometimes a slightly higher but still low dose contraceptive option is needed to manage that bleeding that can be really bothersome in the perimenopausal time frame. So what are some resources? We know that there's a lot of misinformation out there, and so really important for you to be aware of what those credible resources are. So I'm going to provide a QR code in a moment if you want to get your phone ready for the credible sites that we recommend. Menopause Society is a really great international resource, unfortunately not in French, only in English. We know that the Canadian Menopause Society has some patient-facing resources as well as a lot of provider resources. The Society of Obstetricians and Gynecologists of Canada has a Menopause and U site. The Menopause Foundation of Canada as well has a site, and the QR codes are here. So it'll give you an opportunity to grab those sites and to bookmark those sites. And as you're doing that, I'm just going to answer a couple additional questions that came in, and then I'm going to share some exciting news about what's coming next. So one of the questions which I started touching on but didn't completely answer was, are low dose options viable in perimenopause? Perimenopause is probably one of the most complicated things to treat because women often come in expecting or anticipating a certain treatment, such as menopausal hormone therapy, but because she is or they are perimenopausal, they are actually needing something a little bit more, a little bit stronger, a little bit higher dose than a menopausal hormone therapy regime. They're probably needing a medication or an option that will actually take over the cycle and balance the hormones a little bit more effectively. And that would be the mainstay of treatment for perimenopausal cycle control is going to be a combined hormonal contraceptive, such as a birth control pill. IUDs work excellent as well because they'll manage the lining of the uterus. And there's another option on the market. It's called Slind or drospirenone. It's a progesterone-only birth control pill, which protects the lining of the uterus, provides contraception, but can be added to an estrogen patch, a menopausal estrogen patch. So an IUD or Slind are progesterone, and they can be added to a menopausal estrogen patch. Or a birth control pill, as most people are familiar with. But you can treat perimenopause with menopausal hormone therapy as long as the bleeding is manageable and can be tracked. So hopefully, and if it feels a little bit like, oh, there's a lot, yeah, there is a lot in perimenopause in terms of making sure that each person receives the treatment to manage the symptoms that they most are bothered by. And a lot of times, if that's cycle control, it requires something a little bit higher dose than a menopausal hormone therapy. And there's also a question that came in around PCOS, or polycystic ovarian syndrome. Polycystic ovarian syndrome is an imbalance in hormones that can sometimes lead to, so it's an anovulation, so the ovaries aren't ovulating, and because they aren't ovulating, there's an imbalance in hormones, and there's sometimes an increase in male hormone because of that anovulation. So, polycystic ovarian syndrome can be treated by anything that balances hormones, like combined hormonal contraceptive, IUD with progesterone in it, like Mirena, Slind, drospirenone, that progesterone-only pill that I talked about is really good because it has some anti-androgen, anti-mineralocorticoid effects. There are many treatments for polycystic ovarian syndrome that are definitely worth speaking about, that manage those hormone changes that are really challenging for people with polycystic ovarian syndrome. Questions?
Yes, we have quite a few questions. One of the ones is a comment. I had a lot of perimenopause symptoms overlap with stress symptoms. Is there a way to distinguish between long-term stress and perimenopause?
Yeah, I love that question because it encourages us to consider how much stress is okay. So having chronic stress and having chronic stress symptoms that are to the point where you're acknowledging that there's these physical symptoms that are occurring, but you're not sure why, and your stress level is high enough that you're considering the option that all of your symptoms may be related to stress. That's really, really important to acknowledge, to observe, and to start to manage with, hopefully, stress management, which is never going to hurt, and to have a good evaluation for perimenopause. Perimenopause, mostly, as we talked about, the main symptom is going to be hot flashes and night sweats, which in their character are very unique to perimenopause. So you can have hot flashes and night sweats for other, for example, immunologic or malignant issues. That's much, much less common. So hot flashes that last for 30 seconds to a couple of minutes, that come a couple times in the day at different frequencies or durations, is probably perimenopause and probably not stress related. If you start to get stressed and you notice, for example, that you're getting sort of chest tightness, or your breathing changes, or your palms become sweaty, that's more of an anxiety or stress or nervous system dysregulation or stress response versus vasomotor symptoms, which would be more consistent with perimenopause. And the bottom line is, manage your stress really aggressively, because that is probably the biggest improvement in your health, and have a good evaluation to see if your symptoms are perimenopausal.
Thank you for that answer. Another question we have is, I see a lot of comments and articles on menopause and cortisol weight gain. Is this a real thing?
So perimenopause and menopause, as they create the body composition changes that we talked about, there tends to be less fat deposition in the general areas that women used to expect it, so around the hips, the buttocks areas, and there tends to be more fat deposition in the visceral fat, which is kind of in and around the organs, which is why women will often notice central fat or their waistline increasing, or some women have come into my office and say they feel pregnant, or they feel kind of really distended in the abdomen. That can be related to fat deposition in the visceral area, and that visceral fat can be hormonally active, creating the cortisol cycle that feeds into inflammation that you're talking about. So it's a real thing, and the ways to offset or mitigate that is with a couple of things. Stress reduction, even though we don't like to say, well, perimenopausal people are stressed, just relax. That's not the case. It's actual physiology. But stress reduction to keep cortisol at a balance, and muscle resistant training, because that's going to increase muscle, which is going to help with utilizing fuel and reducing insulin resistance. And the cortisol and insulin of the visceral fat have to have some way to get out of that feedback loop. And the best way to do that is through use of blood sugar by reducing insulin resistance in all the ways that we know how to reduce insulin resistance. That's with regular exercise, exercising after meals, reducing high glycemic index foods or sugary foods or simple carbs, and building muscle in order to utilize fuel in muscle so that cortisol and insulin feedback can be balanced with the whole body's physiology.
Thank you. Another one we have here is, if someone thinks that estrogen decline is the cause of their symptom, is it fairly accessible to get hormone therapy through the military medical system? Will we need to have hormone testing for that?
Yeah, that's a great question. So it is very feasible. The military medical system, and I'm just looking up our coverages. So the military medical system you have access to primary care. Primary care ultimately has access to specialists within or contracted with the military medical system. And the Canadian Armed Forces is funded for most menopause medications. So once you've had that evaluation with primary care, and then if needed, and probably not needed because there's a lot of resources within the CAF for providers to become educated or to become even menopause certified, but even menopause knowledgeable. And so I would also propose that if you're accessing the military medical system and feeling like you're not getting the answers, continue to ask the questions, because those resources are available for menopause providers in the military, and the options and resources for treatment options are also robustly covered.
Thank you. We have 4 minutes left, so I'll continue with questions. Do you want to do your announcement first?
Yeah, I want to tell everybody that we'll be coming back, that we're coming back with a proposed date of 27 February, where we can dig deeper into menopause and thriving through menopause, because hopefully as you leave this conversation, you're feeling educated, equipped, and empowered to manage perimenopause, and we'll get back together and dig deeper into the next life stage of menopause on 27 February.
Yes, very exciting. So we will have promotion and links so that you can register for this upcoming webinar in the new year. So you can keep an eye out on our social media and our webpage for this.
Super excited. Yeah, we'll probably have time for another question if there is one.
Sure. So can you speak more to women who may not be a candidate for menopause hormone therapy because of family history of breast cancer? Is there truly a risk if there is a history of second-degree relatives with breast cancer versus first-degree relatives?
Excellent question. So second-degree relative or family history of breast cancer is not a contraindication to menopausal hormone therapy. Menopausal hormone therapy is a very, very, very small dose of estrogen and then progesterone simply to protect the lining of the uterus if you have a uterus. And it's very common for people to have a family history of breast cancer. And although that can be very, very concerning, if you yourself have not had an estrogen, progesterone, or hormone sensitive cancer, you remain a candidate. Very likely, I'm not your doctor, but you remain a candidate very likely for menopausal hormone therapy. And so it should be considered to treat your symptoms. If you want to avoid estrogen, or for other reasons you've been told to avoid estrogen, then there are really good non-hormone prescription options for most of the menopausal symptoms that we just described. They would be antidepressants, SSRIs, SNRIs, or which I've seen work very well for perimenopausal, menopausal symptoms, or neurokinin 1 or neurokinin 1 and 3 antagonists. These are new medications. One is called Veozah or Fesolintant, and it is currently available in the Canadian market, approved through Health Canada. It acts centrally in the brain to reduce vasomotor symptoms. And the other one, Elinzatant, was just approved about a month ago through Health Canada, but it's not yet being manufactured in Canada, but watch for it. It's in a similar category, centrally acting. And because of its neurokinin 1 and 3 effect, it actually has really good studies for improving sleep in addition to vasomotor symptoms. So there's lots of really good options, but I would say for people to just be really really cognizant of the consideration that you may be a candidate for menopausal hormone therapy, even if you think you aren't, and to have that very thorough conversation with a menopause expert.
Thank you, Dr. Hansen. I'll come in with another question, just the last one about sleep very quickly. Seems to be a popular topic. I'll triple up some questions that came in about what should be the goal for hours at night for sleep, and do e-readers impact sleep as a screen device? And then I have one more quick one if you can answer those quickly.
Sure. So there's actually Canadian sleep guidelines available online. I'll find the reference and make sure that we have it available. And it indicates approximately 7 hours sleep. I usually tell people to try to get 7 or 8. And we'll provide that resource for further information. I don't really know what e-readers are, I don't think.
Like a screen reader reading before bed, like a
Kindle.
A Kindle or Kobo, yeah.
Okay. I don't have any data on, the blue light effect of those readers, so I can't answer that, although I would assume that, screens are screens, but also if reading calms you down, then that, you know your body better.
And then the last one on sleep is, until hitting this phase, I was sleeping like a log, always physically active, healthy diet. Now hot flashes, intense itchiness throughout the body keeps me up. What advice to reduce what seems to be full body inflammation?
Yeah, I hope that throughout this presentation, you've received lots of potential answers to that question. I think that without giving you who've asked the question specific advice, menopausal hormone therapy is going to manage almost all of the symptoms you just described and really, really help your sleep. So if you're a candidate for that, speak to someone about that as a first line option.
Thank you. Thank you so much, Dr. Hansen, for this great presentation and taking the time to answer questions. I also want to thank everyone for joining us and engaging and asking questions. It is very great. I'm really looking forward to the next ones on February 27th and a future one as well on more menopause at work. There were some questions that were unanswered, but I'm sure we'll be able to answer them in the next sessions. So again, keep an eye out for the registrations for the next one. And again, thank you, Dr. Hansen.
Thank you so much, everyone. Have a great day.